There we go. So, hi everybody, my name's Rohan. I'm a final year medical student at the University of Cambridge. Today I'm really excited to continue this sort of musculoskeletal theme of this afternoon and talk about some of the research I've been doing with Dr. Nicholas Schenker, who's a rheumatologist at Addenbrooke's. So the primary aim of our research was to determine the factors associated with a positive response to pain management in the Stickler syndrome. So in other words, what makes patients with osteoarthritis with the Stickler syndrome more likely to benefit from clinic? So let's start with a brief introduction to the already existing literature in this field, what our gaps in our knowledge are, and how this study aims to fill in some of those gaps. So previous studies in the past have investigated numerous factors which make people with osteoarthritis generally more likely to benefit from clinic interventions. So this is in osteoarthritis generally, not secondary to the Stickler syndrome. So these have included things like having a higher level of pain, having lower BMI and being of a younger age, and having fewer comorbidities. But no studies so far as we're aware, have investigated these factors in Stickler syndrome patients specifically. So our study aimed to fill in that gap in our knowledge and do that, right? So let's talk about some of the methodology that we used to try and determine this aim. So to quantify pain in patients with the Stickler syndrome, we gave patients a questionnaire called BPI, or the Brief Pain Inventory. So this is essentially a questionnaire which has a series of questions which are shown on the screen, and the patient rates each of these from 0 to 10. Some of you may have filled this out in clinic or seen this before. So over a period of around 10 years, patients attending Stickler syndrome clinic at Addenbrooke's Hospital were asked to fill out a BPI form on each clinic attendance. Some of you may remember doing it. So essentially all of that data that you filled in was put into a massive spreadsheet. And then the patients who were re-attenders, so attended the clinic at least twice, were extracted. And those patients were classified into responders whose average pain score improved by at least 2 points between visit 1 and 2, and non-responders whose average pain score got worse between visit 1 and 2 by at least 2 points. Yeah. Then the responder and non-responder cohorts were characterized and compared using various clinical criteria, which are shown on the screen. The most important ones to mention is that we compared the responders and non-responders in terms of how much pain they're in, what pain management was used for them, and what specific life quality categories were affected. And the basic theory here was that if a factor was more common in the responder cohort than the non-responder cohort, then that seems to be associated with benefiting from the clinic. So for those of you who like to look at statistical analysis in your spare time, here's a slide on that. So basically, when we were comparing two groups of continuous data, so something like age, then we would use something called the Shapiro-Wilk test to see if it was a normal distribution. And then we would use a t-test or a Mann-Whitney test. Now, the basic aim of this is to say, if we have two differences between the responder and non-responder cohort, is that just random chance? Like if I split the room in the middle here, I might find that this side of the room is 10 centimeters taller than this side of the room by complete random chance. There's no reason for it. So these tests determine, is that due to random chance or is there actually a reason behind that? So that's important to do in any statistical analysis. So that's all this slide is saying essentially. There we go. So after we did this methodology and we compared the responder and non-responder cohorts, what results did we get? So in terms of our patient numbers, we had 320 patients, which is quite a large number for a relatively rare condition such as Stickler. Of those 320 patients, 237 re-attended the clinic. And of those 237, we said that 26 out of 237 definitively responded, and 30 out of 237 definitively didn't respond. Okay? So those are our responder and non-responder cohorts. So when comparing the responder and non-responder cohorts, there were three main findings. The first main finding was that the responder cohort had higher levels of baseline pain in all categories of the BPI compared to the non-responder cohorts. So this essentially suggests that people who have higher levels of pain are more likely to benefit from the clinic. And this first finding is backed up by the fact that sort of bad starters, so people who started with an average BPI score of 7 or more, had a net improvement in scores, whereas good starters, so people who started with an average score of only 3 out of 10, had a net worsening of scores. Furthermore, there was a weak negative correlation on the right, you can see, between somebody's initial score and their change in score. So in other words, people who had worse pain scores were more likely to see a reduction in their pain scores, which is a benefit, of course. The second main point was that there was a specific pain fingerprint which is associated with response. Now, what I mean by a pain fingerprint is the order of the life quality categories affected. So when we look at the non-responders, then you can see that the relations category is statistically significantly less affected than the most common categories, by the most affected categories, whereas the responder cohort, that isn't true. So the relations category is just as affected as the others. So that was associated with benefiting from the clinic. Oh, there we go. Nearly lost it there. So the third main point of the findings was that the use of oral NSAIDs, so this is things like oral ibuprofen, was associated with response, whereas the use of topical NSAIDs was not associated with response. So you can see here that the responder cohort had a higher proportion of oral NSAID use, whereas the non-responder cohort was more likely to use topical NSAIDs. Right? So the important negatives when comparing the responder and non-responder cohorts was that there was no significant association between any of the other factors tested and whether somebody's likely to benefit from clinic. So there was no significant association with somebody's sex or their age, for example, or what mutation they have. So let's move on to a discussion of the results, talking about our findings, the implications of the findings, and how we're going to try and take this project forward in the future. So overall, we set out to determine the factors associated with people benefiting from a Stickler syndrome clinic, and we found 3 such factors. 1, having a higher level of baseline pain. 2, having a specific pain fingerprint in which somebody's relations life quality category is affected. And 3, the use of oral NSAIDs. Now, in reality, it's likely that these 3 things are linked. So the main finding of this study is probably that a high level of baseline pain is associated with having a positive response to clinic. So the clinic best benefits people who have high levels of pain. Therefore, those people are more likely to be on oral ibuprofen, because you might have seen that people are put on topical or gel ibuprofen before they're put on oral ibuprofen. So those who have higher baseline pain levels are more likely to be on oral NSAID. So that's why the third category is there. And those people who have higher levels of pain are also more likely to have their relations category affected because it's less sensitive than the others. So the main finding of the results was that high levels of baseline pain are associated with response. So in terms of the implications of these findings, they agree with previous studies in osteoarthritis generally. So remember at the start, I said that these studies have found that high levels of baseline pain is associated with response in osteoarthritis generally. So this suggests that the factors associated in Stickler syndrome may be the same as in osteoarthritis caused by older age, for example, and therefore factors which have been investigated in osteoarthritis patients in general should be investigated in patients with the Stickler syndrome as well. So that's important. Furthermore, by knowing that people with high levels of baseline pain are more likely to benefit from the clinic, we could maybe, encourage them more to come to clinic, especially if they're having to travel long distances, which if you're in a lot of pain is very difficult. And it could present some sort of, opportunity to give some sort of recommendation for setting up clinics elsewhere, especially if we know that high baseline pain is associated with response. And finally, our study suggests that perhaps the use of oral NSAIDs, so oral ibuprofen or naproxen, for example, are associated with benefits in Stickler syndrome osteoarthritis. So in terms of the future directions of this project, ideally we'd like to recruit more participants. Obviously, as we've talked about a lot today, Stickler syndrome is very underdiagnosed. That's not so easy to do. But in reality, if we do that, we can increase the power of the study and maybe find some more associations which we haven't been able to find today. So that's definitely a future direction. Another thing is to look at further associations. We want to look and see, is somebody's BMI associated with benefiting from the clinic? Is somebody's expectations of the management associated with benefit? Is somebody's level of comorbidity, so for example, their level of visual loss, associated with benefit? These are things that have been investigated in osteoarthritis generally, and something that we want to do in Stickler syndrome. And finally, we want to look at the associations between further visits. So there's many patients who have visited the clinic way more than 2 times. So we want to see between visits 2 and 3 or 3 and 4, what factors affect whether you benefit between those visits, and are they different or the same? So concluding thoughts, we set out to determine the factors associated with a positive response to pain interventions in the Stickler, and we found 3 such factors: high level of baseline pain, a specific pain fingerprint, and the use of oral NSAIDs such as ibuprofen or naproxen. So this information could help predict response to pain interventions in the Stickler syndrome in the future, and future studies could use larger patient cohorts to establish further associations. So thanks a lot. Thank you.